Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
So welcome everybody. I'm very excited to share our findings with you and really have a great, fruitful discussion. My name is Joseph Dayan. I'm a plastic surgeon and I've spent my life and career specializing in lymphedema, trying to improve and prevent lymphedema for many patients. And today's topic is GLP-1 receptor agonists may not just be for weight loss, can they actually help prevent and treat lymphedema? I've been exposed to GLP-1s rather recently, although they've been around for a while now. And now many people are taking these drugs and finding that they have effects beyond weight loss and treatment of diabetes. And I'm going to share our recent experience with patients who actually have lymphedema and have went on to take GLP-1 receptor agonists. I think that if they can help with lymphedema, this would be one of the largest advances in this field in my career. So I'd like to first thank LE&RN. Deeply grateful to them to provide a platform for communication of important information to many patients worldwide, and certainly thank all of the generous sponsors for making this talk and all the things that LE&RN do possible. Special thanks to Bill Rapisi, who I've known for years, Phyllis, Colleen, and the team here that's made this talk possible. LE&RN is sponsored information is provided for use. This is for your information. Any medical decisions should be done in consultation with your own doctor or healthcare professional. And this talk is not meant to take place of healthcare services you may need. Please see your primary care provider about any personal health issues. This is really an informational session. These are my own disclosures. Of note, I have no disclosures with any pharmaceutical company that manufactures GLP-1 receptor agonists. I have no financial interest. I do not own any stock in these companies. And this really was a personal journey. This is a patient I had treated back when I was at Memorial Sloan Kettering Cancer Center, where I'd started the lymphatic surgery program 10 years ago. I've since moved on to join the Institute for Advanced Reconstruction, and we've started a Lymphatic Surgery Center for Research and Innovation. But this patient had breast cancer, estrogen-sensitive breast cancer. Like many women, after hormonal therapy and chemotherapy, had gained significant weight. These treatments can alter your metabolism, and even though many women are doing the same amount of activity, eating the same thing, they'll put on a significant amount of weight. And the problem as that pertains to lymphedema is that weight gain worsens lymphedema. This particular patient initially had mild lymphedema. She was actually enrolled in a prospective study in the non-surgical arm, so she did not want surgery, but we were collecting her limb volume, her quality of life scores and imaging. And then all of a sudden she went through endocrine therapy and gained significant weight. And her mild lymphedema then blew up into pretty significant lymphedema. What you're seeing on the left-hand side is when she presented with more moderate lymphedema. She was in compression on the left-hand side 24/7, around the clock. Like many women, she was doing everything possible to treat her lymphedema with lymphedema therapy, manual lymphatic drainage, the pump, and around-the-clock compression. But the lymphedema was increasing still. And it seemed to be associated with her weight gain. I worked with her endocrinologist, a phenomenal doctor, Dr. Emily Gallagher at Mount Sinai in New York, and worked with her on the weight gain issue. My interest was the lymphedema, and particularly, so we worked together. She had treated her ultimately with semaglutide, And for those who don't know what GLP-1 RAs are, or receptor agonists, these are the drugs like Ozempic, Zepbound, Wegovy, Mounjaro, this whole class of drugs. And she had lost the weight that she had gained, went back to baseline, and with it, her lymphedema almost completely normalized. So her limb volume went from 10% of a limb volume difference down to just under 4% of a limb volume difference. But most importantly, she no longer needs compression. So you're seeing her on the right-hand side, totally compression-free. On the left-hand side, she was in 24/7 compression. So her arm actually got a bit smaller and she's compression-free. And if you speak to this patient, she's one of the happiest patients I've seen. This is without any surgical intervention. Of note, we caught this very early, so not everybody's going to respond the same. Interestingly, her ICG lymphangiography, which is imaging the lymphatic system we do on all lymphedema patients that we're doing a deep dive into, looked better. Like we started seeing the beginning of a lymphatic vessel that we previously did not see. And this was ultimately published in a case report along with Dr. Gallagher, Dr. Stav Brown, and Dr. Finn Crowley. And this is a case report is really a deep dive, a microscopic view of one singular patient. You need multiple patients to have a scientific study. But this piqued enough interest because of the time course of the weight gain, the worsening of the lymphedema, the GLP-1 subsequent weight loss, and almost elimination of the lymphedema. After this case report, we just see patients that on their own accord go on a GLP-1 because they are contending with weight gain or diabetes or both. And so we've seen significant limb volume reduction anecdotally and improved quality of life, improved bioimpedance scores in almost a dozen patients now. So this is one particular patient who her initial ICG just showed no lymphatic vessels, just all whited out. You couldn't see anything identifiable. She went on a GLP-1 receptor agonist for about 3 months. At that time before, she was not really a candidate in my mind for lymphovenous bypass because I couldn't see anything to bypass. But now I'm showing you her ICG on the OR table with a very clear, identifiable lymphatic that's bypassable. So she was a non-bypassable patient, and then we were able to do this lymphovenous bypass. You're looking at a lymphatic. This is about a 0.5 millimeter lymphatic plugged into a vein. And so it was pretty amazing that you can take somebody who maybe is not a good surgical candidate and turn them into somebody who might benefit from surgery, as well as treat somebody who doesn't want surgery or is not a candidate for surgery and them actually have a benefit. So going a little deeper into GLP-1s, just a few years ago, they weren't widely known, but now pretty much everybody's heard of these drugs. I'm actually on the drug myself for diabetes, which has been a great benefit for my blood sugar, which was way out of control. I have family members on this drug. This poll showed about 1 in 8 people in the US alone have at least tried a GLP-1 receptor agonist, and about 6% of the entire country is on this drug. So many people are taking this drug, breast cancer survivors, other cancer survivors, and of course the general population. And it is important to have this discussion early on, which I'm really looking forward to this whole audience, because there are going to be people that know a lot more about GLP-1s than I do. I am not a GLP-1 expert, but I am an expert in lymphedema, and I rely on the knowledge of oncologists and the endocrinologists prescribing them. So I think together, through multidisciplinary collaboration, we can carve out a course where we can study this at a high level and really get the answers to the patients that the patients need. We know that GLP-1 receptor agonists cause significant weight loss. This was an FDA trial, double-blinded, randomized controlled trial on over 2,500 patients. A randomized controlled trial is the highest level of study, and it is the best way to see if the drug actually causes the effect that you're looking for. And this study found that for this particular GLP-1 receptor agonist, there was a 15 to 20% body weight loss, depending on the dose, compared to 3% in the placebo group. That means patients actually taking the drug had a significant body weight loss, and people that were just given a placebo or were not really the drug, didn't know they were receiving it or not, didn't have weight loss. Double-blinded means that the people receiving the drug didn't know if they were getting the actual drug or if they were getting a fake drug. That was really nothing. And on the other hand, the people that were measuring the body weight also didn't know if the person they were measuring got the drug or didn't get the drug. So this is a very high-level study showing that definitely this drug causes that amount of weight loss. The most common adverse effects, which of course are a concern for any drug, is their safety. And these were largely GI symptoms, mostly nausea, vomiting, constipation. And in this study, about 5% of patients basically discontinued therapy because they could not tolerate it. So it's not for everybody, but a lot of people are taking these drugs. Beyond the weight loss and glucose management, these drugs have been found to be cardioprotective. They actually reduce the risk of heart attack and stroke. Not every diabetic drug does this. And this is one of the reasons I decided to take this drug. I think that this drug actually acts directly on the coronary arteries, the arteries feeding blood to your heart. There are GLP-1 receptors on these vessels, and so they seem to have a beneficial effect. And a lot of these mechanisms of action of how the drug is benefiting other organ systems is a big topic of study. This is a great review article looking at the effects of GLP-1s have been studied on the brain, on the liver. This has been shown to reverse fatty liver. It seems to have beneficial properties for your brain and possibly for some neurologic diseases. There are multiple organ systems that have GLP-1 receptors, and this drug binds to those receptors and turns them on. That can have downstream effects. And consequently, these drugs have been used off-label at an increasingly high rate. Off-label means that the FDA has approved these drugs for treatment of obesity and diabetes, but there might be other benefits. So if, for example, there is a benefit for a patient with lymphedema, that's considered off-label use. And I've seen publications of this being used for a variety of all kinds of diseases, from autoimmune diseases to neurologic diseases. And so there's a whole flurry of study and interest in other beneficial effects. So dialing back into the first patient I spoke about, and this doesn't just apply to patients who have breast cancer-related lymphedema. I've seen patients or had anecdotal reports of patients with primary lymphedema that have reached out to me that have seen a beneficial effect. So this is an area that still requires a lot of study. But there are a lot of things we do know. So we do know that in this MD Anderson cancer study, about a third of women treated with endocrine therapy, this is hormonal therapy for hormone-sensitive tumors, estrogen-sensitive tumors, developed significant weight gain. Other studies show reports of upwards of 50% of women undergoing breast cancer treatment have significant weight gain. And the metabolism is really altered by some of these treatments, where they're doing the same thing, eating the same thing, but they're gaining 20, 25, 30 pounds, and their body composition just dramatically changes. And so this has an effect on lymphedema. We know that elevated BMI or body mass index, body weight, increases the risk of lymphedema. This has been reproduced in multiple studies. There's an intimate relationship between fat cells and lymphatic cells. And this was a 5-year prospective study on over 900 women, finding that preoperative weight and BMI are significant risk factors for developing lymphedema. So this is something that's of great interest and concern. This is something that can be improved. It's something we can potentially manipulate to reduce the risk of lymphedema, but it can be hard to drop BMI, especially changing lifestyle, or if the metabolism is such that it's resistant to typical diet and exercise. Despite best attempts, that weight stays on. This is another study showing over 900 patients with axillary dissection followed for 20 years. This was a study done at Memorial Sloan Kettering Cancer Center, a very dear institution to me. Weight gain and infection or injury were the two main risk factors for developing lymphedema. So it's not just a high body mass that puts you at higher risk. If you have a weight gain during that course after your cancer treatment, you have a higher risk of developing lymphedema. And in this study, over 20 years, found about 3/4 of all women that were going to develop lymphedema developed it in the first 3 years after the cancer treatment. So most lymphedema occurs in the first few years. Not only that, but obesity alone, no cancer, no lymph node dissection, no other factor, obesity alone at very high levels, BMI in excess of 40, 50, 60, can develop lymphedema spontaneously. And that's because there is a close relationship between the fat cell and the lymphatic vessel. And laboratory study, this was done by my colleague, Dr. Marara, Dr. Kataru and colleagues, they had found that in a mouse model, in obese mice, there's a lot of inflammation that gathers around the lymphatic vessels itself. And that localized inflammation around the lymphatic vessel causes the vessel to become leaky. It reduces its ability to pump lymph. Its function just deteriorates. And so increased fat cells increase inflammation and deteriorate the lymphatic function. And so that's where GLP-1 receptor agonists come in. And we know that GLP-1 receptor agonists can reduce body composition, the fat portion of body composition, can reduce inflammation, and by that mechanism may improve lymphatic function. But there are always the question of safety and risk with any drug. There's no such thing as anything that has no risk. You can drink 10 gallons of water and get cerebral edema and that can be fatal. A Tylenol has very little risk, but in certain patients can be devastating. GLP-1s are widely used, so there's a lot of data on risk. But if we're using this on patients with a cancer history, of course, the cancer risk becomes of primary importance. So what about cancer risk in GLP-1s? There is a box warning label for thyroid cancer, for semaglutide, for example, because in a rodent model, there were higher rates of a certain type of thyroid cancer found. A rodent model and a human being are very different. So you have to also look at real human population. This is a study and a meta-analysis of 37 randomized controlled trials of semaglutide used in over 16,000 patients. In this meta-analysis, meaning they're looking at other studies and pooling all of the data. So instead of saying, I looked at this study of 500 people and another study of 1,000 people and 12 other studies, we're pooling all of that information and we get a much higher number. So in this case, 16,000 people. In RCT is the highest level of study. It's the most sophisticated study design, showing that the drug is actually causing the effect. So a randomized controlled trial. This was a study looking at only high-level studies and did not find any significantly increased risk of any type of cancer. Now, there are other studies that have been published that show some significant risk of a certain type of cancer, and other studies that contradict all of this. But looking across a large swaths of high-level studies, increased cancer risk doesn't seem to be standing out. That being said, I would put a caveat that these studies haven't been over 20 years, 10, 20 years. So the length of the study is very important. If you're only looking at cancer recurrence and your study interval is 1 or 2 years, that doesn't really tell you a whole lot. You're really interested in what is the cancer risk over 5 or 10 years. So because these drugs have not been around for 20 years, we obviously don't have ultra long-term data. And there are other studies looking at diabetics. So this was looking at a diabetic population. Diabetics are on a lot of different drugs. And one of the questions are, do any of these drugs, other drugs like metformin and glipizide, all of these different drugs, is there any increased cancer risk with them? This was one study that did not really show any specific tumor risk. We do know that a GLP-1 receptor agonist in a lab, there are laboratory studies, do these drugs promote cancer growth, or do they actually slow cancer growth, or do they have no effect on cancer cells? This is a really important question. And by what mechanism does that happen? So when you're looking at in vitro or looking at a dish, anecdotally like in a test tube or in an animal model, you're really looking at how the drug acts to promote or suppress cancer, or maybe it has no effect. By what mechanism, by what pathway does this happen? And so these are 2 laboratory studies, controlled studies, not in an actual human being, that showed inhibition of certain types of cancer, such as pancreatic cancer cells and ovarian cancer cells. Now, that does not necessarily mean in a live human being you're going to find the same result as in a lab. So what about studies looking specifically at breast cancer? Not just the general population of people, most of whom don't have cancer, but looking at a population of people who actually have breast cancer. And so this is these are specific, these are lab studies. This is in a dish, basically. And this showed that GLP-1 receptor agonists may cause estrogen receptor positive breast cancer cell death. Again, these are just 3 studies. This is not something you can apply and then make a conclusion about human beings in general. But for estrogen receptor positive human breast cancer cells in a dish, GLP-1s apparently suppress tumor growth and promote cancer cell death or suicide of the cancer cells, which is a good thing. On the other hand, these 2 other studies found the opposite in triple negative breast cancer. So not all breast cancers are the same. Most breast cancers are hormone sensitive, estrogen receptor sensitive, but more aggressive forms of breast cancer, such as triple negative breast cancer, which do not respond to endocrine therapy. In this study, GLP-1 receptor agonists, specifically liraglutide, seem to promote cancer cell growth in a dish and in a rodent model. Again, these are just 2 isolated studies in a lab. They cannot necessarily be applied to an actual living human being, but they are important to understand what these pathways are, and we have to look at all of this with very high scrutiny. Now, those studies were in a lab. What about in a real human population? What do we find? Sometimes we can find all kinds of things that seem to cause cancer in a mouse, but really do not have any cancer risk in a human being. There are other different variables, such as what was the dose given to the mouse? Was the dose 100 times the dose experienced by a human being in a real world setting? Are the receptors in that mouse present in the same density in the organs of a human being? These things are very, very different. So this is a study asking, do GLP-1 receptor agonists increase the risk of breast cancer? This was a systemic review, meaning they're looking at the literature in general, everything that was published, and a meta-analysis. Again, that they are looking at studies of a certain level and pooling all the data to get a higher number. And in this publication, there was no significant difference in the incidence of breast cancer in patients taking GLP-1 receptor agonists. Specifically, there were over 48,000 patients treated with GLP-1 receptor agonists and 130 diagnosed with breast cancer and another 40,000, over 40,000 patients in the group that did not have any GLP-1 drug. 107 were diagnosed with breast cancer. Even though those numbers are a little different, they're not statistically significant when you're taking in the tens of thousands of patients in the study. But this was a general population. This is a registry study of over 1.6 million patients with diabetes taking GLP-1 receptor agonists, and actually found a reduced risk of certain types of cancers in the actual human population. So we do know that obesity is associated with increased cancer risk of certain types of cancers. That includes colorectal cancer, breast cancer, ovarian cancer, and other types of cancer. So the question was, if patients who are being treated for obesity with GLP-1 receptor agonists and they lose significant body weight, could that reduce the risk of cancer? This study suggests that actually may be the truth. However, it is a registry study, and a registry study is a very large study, which is very useful to have 1.6 million patients, but it is a backwards, retrospective-looking study. So you're not asking the question up front, setting how you're going to measure the outcome, and then collecting the data. This is looking at data that's been collected and trying to make sense of it. I think the reduction in ovarian cancer risk, if real, is also of interest to patients that have BRCA2 gene mutations, as they are at increased risk, for not only breast cancer but ovarian cancer. This is a subject we have to study and dig in deeper. So we did publish another study when I was at Memorial Sloan Kettering in collaboration with Dr. Stav Brown, Dr. Tadros, Dr. Montagna, Dr. Emily Gallagher, wonderful and talented endocrinologist at Sinai, and Dr. Finn Crowley and others. So we looked basically at a registry of patients who underwent axillary lymph node dissection at Memorial Sloan Kettering Cancer Center, and we looked at any patient that was taking GLP-1 receptor agonists, asking the question, are patients that are undergoing removal of their lymph nodes under their arm, if they're taking GLP-1, do they have a reduced risk of developing lymphedema? Because basically removal of lymph nodes under the arm puts that patient more or less at risk of 1 in 3 of getting lymphedema. Very, very high risk. So what we found was that 28.5% of patients who were not taking GLP-1s had lymphedema in the non-GLP group, compared to only 6.6% of patients in those that took GLP-1 receptor agonists. To clarify this a bit, of those 3,800 patients, only 76 were taking GLP-1 receptor agonists, so not a huge number of patients, but that is a very big difference. There was a similar follow-up time in both groups, a mean follow-up time of about 2 years. And 2 years, the majority of patients will develop lymphedema in the first 2 years, and 3 out of 4 patients will develop lymphedema in the first 3 years after breast cancer treatment. So it is a reasonable follow-up, not ideal, but very reasonable. And also importantly, this was the only study that I saw that looked specifically at cancer patients taking GLP-1s. And of those 76 patients on GLP-1s, none had developed a cancer recurrence. Now, this was not a specifically focused oncologic study asking the question of cancer recurrence in GLP-1, and it is a question that is going to require long-term follow-up. So in addition to weight loss and insulin control, because insulin resistance and diabetes are also risk factors for developing lymphedema, those 2 ways certainly are probably the main ways that GLP-1 receptor agonist could benefit somebody with lymphedema. But the GLP-1 receptor agonists also have anti-inflammatory effects. These are well documented, and immunomodulatory effects. And some of those are just along the same pathway of causing lymphedema, specifically the CD4 activation of CD4 positive cells. and the cascade that occurs downstream of that, leading to fibrosis, scarring, fat deposition, and general lymphatic vessel dysfunction. So this is an area of future study, actually looking directly the mechanism of action of how does this drug actually improve lymphatic function if it does. So in summary, obesity and diabetes have been known to have a negative effect on lymphatic function. GLP-1 receptor agonists are very effective at treating both obesity and diabetes. And there is anecdotal evidence of a number of patients we've treated of GLP-1 receptor agonists improving lymphedema, where we have significant limb volume reduction, significant improvement in bioimpedance, and significant improvement in their impairment scores. So in summary, GLP-1 receptor agonists may reduce the risk of lymphedema. And if they do, it would be the biggest advance in my lifetime for lymphedema on the non-surgical side, because currently there is no drug widely used that I've seen that's been effective in treating lymphedema. There are drug trials ongoing, and I think it's important to have as many drug trials as possible. I know Dr. Roxon has been a great contributor, Dr. Marara's lab, and others around the world. But at the same time, as exciting as this is, safety is number one, and we need a complete picture of the long-term risk of and benefit of these drugs, particularly in patients who have had cancer or being treated for cancer. And so as a surgeon who sees patients with lymphedema every day, I am not the GLP-1 expert, but I focus in on how can a patient walks into our office, they are distraught with lymphedema, and I'm interested in any way we can help that patient, both surgically and non-surgically. And there are going to be people in this audience that know far more than I do and have published on GLP-1 receptor agonists. And so I would be very eager to speak with you, to connect with you, and to collaborate with you because we do need endocrinologists and specialists and researchers on GLP-1. We also need oncologists and specialists on the cancer side, as well as specialists on the lymphedema side. And before any surgery, we always try to optimize patients. So historically, a patient would come in for interested in surgery. If they were a candidate, we would first want their body to be optimized with good exercise, weight loss where indicated, good sleep, and of course, very good lymphedema therapy to optimize their limb. We also more recently, as I've become a fan of continuous glucose monitoring because it's changed my life and family members, and I've seen patients that I've recommended it to, and it's been transformative for them. This is now something over the counter you can get in the US for $99 for a month. Again, I have no disclosure, and it will tell you exactly what happens to your blood sugar when you put something in your mouth. And even if you're not a diabetic, like I was not a diabetic a year ago, but I felt that if I would have had that knowledge and I would have modified certain things I thought were healthy that were actually bad for me, I could have potentially dodged a bullet. Many people in the US on our American diet are on the road to prediabetes or diabetes. So the next question I have is maybe GLP-1 receptor agonists could be part of this optimization. However, because this is an unknown area and I've not seen a prospective study to evaluate the effect of GLP-1 receptor agonists on lymphedema, we are rolling out actively a prospective study looking at the effect of GLP-1 receptor agonists to treat lymphedema. And if there are people that are interested in this study, I'd encourage you to reach out to us. This is only part of our team. It's constantly growing. I'm very fortunate to have such a talented team. We have 2 full-time dedicated lymphedema nurse practitioners. We also work with Dr. Cutler, who is an internist and is helping us with the GLP-1 side and general medicine side of everything, as well as 2 full-time registered nurses, a full-time research staff, 2 PhDs, a research director. So we're looking at everything and we want to scrutinize this. Right now, a lot of people are taking these drugs anyway. We want to actually study what's going on to make sure patients can understand the safety, the risk and benefit, and make a decision for themselves in conjunction with their oncologist when appropriate, and also to see the effects in primary lymphedema. Patients are eager for a solution or any benefit. So we just can do this together safely. And I just wanted to start this discussion, and I'll open it up for any questions, thoughts. Please, you can be as harsh as you like. I'd welcome it. This is a big unknown, and I look forward to your comments. Thank you so much. So this is a good question from Ahmed. So could GLP-1 receptor agonists be used for congenital lymphedema in children, and for how long could they be used without complications? That's an excellent question, and I think there are going to be more questions than answers, but we are definitely interested in seeing the effects in primary or congenital lymphedema. I don't have any experience or any knowledge in a pediatric population of using GLP-1 for lymphedema. I think that I would start getting data and high-level information, prospective information on adults first. But I do know of some people that are using this drug. So the bottom line is I don't know, but it's a very important question to answer. Then this is another question from Cassie. Sending this question on behalf of my organization's CEO, Jonathan Cart of Lymphedema Foundation. Do you see patients with lymphedema? If so, do you have any insight into GLP-1 use in the lymphedema patient population? Excellent question. Lymphedema patient population is very dear to me. I personally am focusing on lymphedema, but my colleague, Dr. Russ Ashenoff, is doing a lot of lipedema, and we're collaborating. So I actually traveled to Germany, to Hinterzarten, with a number of people, experts in lipedema long ago, over 10 years ago, as well as some people suffering from lipedema, going for liposuction to treat this. But I don't have any specific experience treating lipedema with GLP-1 use, but I think this is an important thing to study prospectively and carefully, for sure. So this is from actually a patient. I have both lymphedema and lipedema in my legs, stage 4. It's very severe and disabling situation. How do you get insurance to pay for these drugs? I'm on disability, on Medicare, won't cover the cost for these drugs. Not a candidate for surgery because of high BMI. So I think that I couldn't answer, honestly, insurance coverage questions. I'm definitely not an insurance expert. I do know that there are certain, depending on what your BMI is, there are certain insurers, and I don't know about Medicare, that would qualify based on BMI or BMI with some other comorbidities, like some other medical issues. But I couldn't comment on Medicare coverage for this. This is a big problem. So we see patients with lymphedema who don't have obesity or diabetes, or for whatever reason, their insurance won't cover it. And when we're using this to treat off-label for lymphedema, even if it may help them a lot, it's an area that is difficult to get insurance coverage. There have been a couple times where I've written letters, and the insurer, in combination with the endocrinologist, in certain specific cases, we were able to get the insurer to cover, and the patient had a significant benefit. But in general, I couldn't give you specific guidance. Hello, I'm wondering if you can speak to the effect that GLP-1 receptor agonist medications have on patients with lipedema, both lipedema and lymphedema, lipolymphedema, and if there's a specific GLP-1 receptor agonist medication that would be recommended. That's a great question, and I think it just shows there's a high interest in what could this drug do for somebody with lipedema or lipolymphedema. I couldn't comment on the specific GLP-1 receptor agonist. I can tell you that the patient treated in our case report, and you can read that case report, it's open access, you don't have to pay anything, it's free online. But she was treated with semaglutide. She was treated with another GLP-1 that wasn't particularly effective or as effective in her. That worked for her. Everybody's metabolism will be different. The newer GLP-1s like tirzepatide have shown a higher level of weight loss. There are also formularies, pharmacies that are basically making these drugs, which I'm not as familiar with. So this is a person who's been on GLP-1 a few years for pre-diabetes, and endocrinologists thought it would help pain in her lymphedema. She's now on Zepbound, was on Mounjaro, and then Wegovy. She's had lymphedema in thighs and legs and possibly the left arm. She's lost 50 pounds over. I don't see the part. I'm not sure I see the part. It seems like it's cut off, so I don't see the question. I'm sorry, my apologies. I'd be interested to know what your experience was, though. What if you had lipedema and the lymphedema is secondary? Since lipedema is not responsive to diet and exercise, do you think these drugs can still help? Again, I think there's a tremendous interest in the lipedema community, which can be very difficult to treat. And I think this is something that you would want to do in a prospective study. And it's something that we can think about. We have the bandwidth to do both lymphedema and lipedema. Do I know if they're effective in primary lymphedema? I can only tell you anecdotally, I've had a couple patients reach out to me that have reported improvement in use in primary lymphedema. But again, I don't have any high-level study. I think it needs to be studied. How long does a primary lymphedema patient need to take this? It's a very good question, and that's also part of the reason we need to study it. So is this something that you can take for a few months, get a tune-up, and then stop? Or is this something that's long-term or even lifelong? I don't know. The drugs haven't been out for 20 years. We don't know the much longer-term effects of these drugs. And that's why I think that using any drug should be weighed against the actual real-world problem you're facing. So if you're facing a severe problem, for me, for example, the diabetes was out of control. That was a very real problem now. And I'm weighing that against a potential future unknown risk and some known risks in the near and short long term. So the problem, I think, has to be big enough for you to use a drug if there are some unknown risks that you're concerned about. And certainly lymphedema and lipedema, depending on the person, can fit in that category. So this is a patient has primary lymphedema, started taking Mounjaro to try to lose weight within 2 to 3 hours after the first injection. The tissue pressure that she felt 24/7 ceased. She lost almost 10 kilograms the first 2 weeks, and I believe it was mainly lymph fluid. My MLD therapist commented how different my limbs felt. 8 weeks later, I have almost no pitting edema. I was not aware of the potential for Mounjaro to treat my lymphedema. I only started looking into it after I noticed the difference it made to my symptoms. And these are the kind of reports that I'm getting more and more of, not just from our own patients, but from all over, which underscores the importance to actually study it. So I think that there is something really there. Is the use of medication recommended before or after a surgical procedure for lymphedema? I guess my question is, does the use of medication eliminate the need for surgery or the other way around? Very, very good question. So depending on the type of surgery you're talking about, I'm going to assume you're talking about cancer surgery removing lymph nodes. Let's say the most common in the US would be axillary lymph node dissection for breast cancer. The way I see this problem is two problems. One is there is a mechanical problem, like your lymph nodes were removed, a big bite out of your lymphatic and immune system was taken, and there is a defect. Just as a woman would have, just as you're removing the breast, you would be offered the option to reconstruct the breast. Or if a nerve was cut, you'd be offered the option to reconstruct that nerve. Well, removing all of those lymph nodes, that's not an insignificant part of your lymphatic system. And I do believe that there's an opportunity to reconstruct that defect, and that should be, if available, offered. No different than you would reconstruct a blood vessel or a nerve or any other important organ. I don't see why you would neglect reconstructing that part of the lymphatic system. And we do have data that it does reduce the risk of lymphedema. However, that's just focusing on the defect itself. I believe that the second part of the lymphedema is the immune response to that bite out that was taken out of it. The immune system may respond aggressively with inflammation and a whole inflammatory storm of chemicals that will cause scarring of the lymphatic vessel and lead to lymphedema in about 1 out of 3 patients. So that part I think is probably best treated with a drug, modulating inflammation and an immune response. And certainly, if you can alter the weight, body composition, or improve insulin resistance in a patient that are known risk factors for developing lymphedema, why not do both? Why not reconstruct the lymphatic system and treat the whole body holistically? I think that would be ideal. That being said, not everybody is going to want surgery or has surgery available to them. And so if this was my body and I had to undergo an axillary dissection, given what I know, I would probably, if surgery wasn't available, take the drug. The question is, how long do you take it for, at what dose, and so forth. So these are all more questions than answers. Are you aware of similar changes in results with lymphedema that we discussed? So this is a patient who's had lymphedema for 13 years, post-metastatic melanoma in the left leg. She's been on Zepbound for 5 months and has lost 35 pounds. It's made a tremendous difference in my lymphedema. I too am in compression, except to sleep and use pneumatic compression twice a day. Hopefully one day insurance will cover the cost of these drugs, as they are so expensive, which will be a barrier to many patients. I hear you 100%, and I'm with you. And I think this is another report of somebody who has experienced a significant benefit in their lymphedema. This is from Sharon. Would the medication be beneficial for lymphedema patients that are not overweight? Similar to other questions, these are very good questions. And I think how you define overweight is important. But I would say that if a patient was, say, not overweight from a medical BMI standpoint, is a BMI of over 25, obese over 30. BMI is it is a rough estimate. So if you have a lot of muscle mass like a bodybuilder, you're going to have a high BMI, but not necessarily high fat content. But barring if you're not a bodybuilder, if you went on to gain a lot of weight and your lymphedema worsened with the weight gain, I think that's one scenario where appropriate treatment with GLP-1 to lose the weight you gained would be fine. But I would be very hesitant I would not necessarily, I wouldn't be comfortable putting somebody who's thin on GLP-1 for lymphedema, and I would leave all of this up to an endocrinologist. So I want to be very clear that I'm not an endocrinologist, and I do not prescribe GLP-1s, so I don't want to be making recommendations. These are my own, as an outsider, observations. Oh, this was continued, sorry. This is the patient that lost over 50 pounds over the past 3 years, has another 50 more pounds to lose. Is there a better brand for lymphedema or lipedema? She's pre-diabetic and also wants to prevent non-alcoholic fatty liver. No one knows how I got lymphedema or lipedema. I was on statin Crestor when it started, severe cramps in the legs, so the statins were discontinued. 71 years old, on compression. This is a very specific question, specifically to your medical condition, which I can't really answer. Again, I'm not an endocrinologist, so I couldn't make a recommendation on a specific type of GLP-1 receptor agonist. This is a question for Veronique. Have any studies been done with non-prescription GLP-1 supplements, not the actual GLP-1 that is injected? Thank you. Great question. So there are compounding pharmacies that you do need a prescription for that are not from the actual manufacturers, namely Eli Lilly and Novo Nordisk, that are producing the GLP-1s. And then there are non-prescription supplements that I'm just honestly not familiar with, and I'm not familiar with any study on them. I think that regarding the compounding pharmacies, I'm also not terribly familiar with specifically with compounding pharmacies. I know that there are major institutions that are using them because there have been supply shortages, and so patients couldn't actually get the drug they needed for diabetes. Can we share screenshots from the webinar? I would leave that to learn. Would these be available in Ontario, Canada? I honestly don't know. Another question on primary lymphedema. I think these are very, very important questions, and that's why we will be studying the effects both in secondary and primary lymphedema. Quick question: how do the GLP-1s work on the lipolymphedema patients? Again, good question. How does the doctor write the prescription to push it through insurance? There is no way to write the prescription. It's just a prescription for the drug. Your insurer is going to be the one that determines whether it's medically necessary or not, and insurances vary widely. Generally, this is covered for obesity and or close to obesity with multiple other medical issues, but that's between you and the insurer. So are there any problems if these drugs are taken for a patient with a full thyroidectomy for cancer and also primary lymphedema in the leg? So I would refer any question regarding cancer to your oncologist. I think these are important questions. That's why we're going to be studying this in concert with the patient's own oncologist. Oh, this is a dear patient of mine, which I want to send my warm regards to. Will there be any trials? Yes, we are enrolling. We are going to be actively rolling out in the next month our prospective study for using GLP-1 on lymphedema, and they will be for both lower and upper extremity. And it is great to hear from you, and I'd love to connect anytime. So what do you think of GLP-1 use, again, in primary lymphedema in a patient of normal weight? Again, I think this is a question really for your doctor who's prescribing the GLP-1 specifically to your weight and your medical conditions, and how severe they are, and if the risk-benefit makes sense. I would not want anybody that couldn't afford to lose weight to lose weight in an unhealthy way, but best answered by your doctor. So have you found that people need to be on maintenance dose of GLPs to prevent lymphedema? Great question, and we don't know. So from the registry study, we don't necessarily know. It's hard to know how long those patients have been on GLP-1s. I can tell you that they were all in our group on for at least 1 month. But is this something that you need to be on for a few months, a year, a few years more? Time, we need time and high-level study. Again, are they on GLP-1 for their lifetime? We don't know, because GLP-1s haven't been around for a lifetime. I can tell you, this is just from my own experience of being on a GLP-1, there is a kind of culture where maybe it's the algorithm online where not just taking this drug, but also doing continuous glucose monitoring, and that has resulted in me modifying my diet, which has definitely benefited my blood sugar and overall health. And then that also makes me more aware of getting enough sleep, getting regular exercise, none of which I did. I was a surgical resident and surgeon for most of my life. eating horribly, sleeping very little, high stress, high cortisol, high blood sugar, eating, ultra processed foods from a vending machine. So for me personally, starting the GLP-1 was part of a journey of getting feedback I have my glucose monitor on the back of my arm. Now I have constant feedback of what I put in my mouth. And so for me, it was a part of the journey of being healthier overall. Is there a point where one could disengage from the GLP-1, having it alter their lifestyle in other ways where they don't need it? I think it's very possible, but I think that's very individual and is between you and your doctor. As a registered dietitian that works with cancer and lymphedema, I really appreciate you pulling all the research together. Thank you. And I want to say thank you to the dietitians, because I think that having a diet, I think that having not just blood tests where we relied on, we send people to nutritionists and dietitianists routinely, and usually historically the only information we would get would be sent a battery of labs and blood tests, and we kind of get a snapshot in time of the patient's general nutritional status. But now with continuous glucose monitoring, again, I have no disclosure for any CGM company, is now we have real-time immediate feedback. And so patients, nutritionists, dietitians can dial in specifically for that patient what makes sense for them, because a healthy diet for somebody else was not healthy for me. So I think it's a very exciting time for the field. I have a client that is morbidly obese, non-ambulatory, has bilateral leg lymphedema, prediabetes. He's concerned about using a GLP-1 due to the risk of edema, which they read about. Your research to date doesn't seem to show that. Any comments? I think it's a very important question. I haven't seen, of the patients that I've directly interacted with, I have not seen that. I have not seen edema caused by GLP-1. But again, this has not been done in a study. That's why we're going to do a prospective study. And I think that that the real world risks that any one patient is experiencing now have to be weighed against potential or unknown risks. And so for some patients, the problem they're dealing with now is so disabling and such a big problem that it may be worth with their doctor trying a GLP-1 and clearing it with their oncologist, clear it with your doctor. Your situation is going to be different from anybody else's. So I think that's an important discussion that needs to be done with that patient's physician. What is the criteria of your study? These are going to be patients with, we're going to have a couple different studies. One study is focusing specifically on the breast cancer-related lymphedema population, because those are a high number of patients that we see. And there are different types. There's people who have triple negative disease, people who have estrogen receptor positive disease. But we will be studying also primary lymphedema and lower extremity lymphedema. Most of the primary lymphedema we see is lower extremity lymphedema, and we see a lot of it in our clinic. I am hammering out more details because and part of this is to open up the discussion, because I am speaking to a number of oncologists, a number of endocrinologists and physicians, because in the development of this study, I don't want it to be a person who's specializing in lymphedema, looking at it from an angle of just lymphedema. We really want to look at the oncologic implications as well as the actual endocrinologic and internal medicine component. But the study will be rolling out in the next month. Thank you for the amazing presentation. Thank you so much. What are your thoughts on GLP-1 microdosing? Great question. What is the optimal BMI range you want to see in a patient with lymphedema? So these are great questions. We discussed maybe if somebody is not overweight, is there a role for microdosing? I have no idea. I don't know of any data. I think it's an excellent question and an excellent subject for future study. And in terms of optimal BMI range, we don't have the cutoff is somewhat arbitrary for surgery. this is, I can just speak from my own experience, is that I wouldn't say that there's a target BMI, a specific target BMI. Everybody's different. Everybody has a different thermostat and metabolism. But historically, I operated on patients, regardless of BMI early on, when we really didn't know anything. There wasn't any data. And that was out of compassion. The patient, you're facing a patient that has a real problem, is really distraught, and you want to help them. In the absence of any data, you tell them risks unknown and known, and you go on, and we did the surgery. And I just found that for surgery, there was a high failure rate and also not an insignificant complication rate. So we dialed in the BMI to technically under obese, which would be less than 30 for surgery. And that's in order to protect the patient from having a complication without giving them any significant benefit. That is not a hard cutoff. There are patients we have operated with a BMI over 30, and there are patients that will benefit with a BMI over 30 in surgery. It was just at the time of developing this, what can we do non-surgical first to give that patient the best chance of actually having the best benefit? So for the actual drug for GLP-1, I don't know what that is. And I think that's also going to take prospective study. And this is also discussion with the patient's doctor. Will the study be blind? No. I wanted to do a randomized placebo-controlled, at least blinded study would be great. I did approach Eli Lilly, because that would cost money to supply the drug, to supply the placebo. That's not something we have funding for. That would give you very high level information of whether GLP-1 causes an improvement in lymphedema, because the patient doesn't know if they're getting the real drug or not. So I think that's a great question and an ideal situation, but that never came to fruition. At this present time, there are people just taking this drug. So I think if they're taking it anyway, we should at least be measuring them. We should at least be following them. So we'll learn what their effects are, not just that they're reporting and they feel things are good, but we can measure and say, you know what, your lymph volume, you feel better, but your lymph volume hasn't changed. Or you feel better, your lymph volume actually changed and reduced dramatically. These are important things to study. Thank you so much for your attention. I'm a longtime primary lymphedema patient diagnosed at 21 years old and now 48. That is very difficult. I'm extremely fit, but I'm curious if surgery is possible when the disease has been in me for so long. I just had a radiology test ordered and plan to reach out to you for an appointment. Absolutely. I don't think that necessarily because you've had longstanding lymphedema that it excludes you from surgery. In general, it really depends. There are different types of surgery for different types of lymphedema, and everybody's situation is different. But we have treated primary, long-standing, decades-long lymphedema successfully with surgery. Not everybody's a candidate, and we need to fully image you, fully evaluate you. But we look forward to seeing you. Another question about lipedema. Could you qualify for the study if already on a GLP-1? We're really looking ideally at patients who are starting out at baseline, not on a GLP-1 receptor agonist, and then go on to have a GLP-1 receptor agonist. That being said, patients that are already on GLP-1 receptor agonists, but do not necessarily qualify for the prospective sort of high-level study, we are maintaining a registry, a prospective registry that will track patients such as yourself that are being treated, because we want to see your trajectory. We want to see how long patients are taking this drug for and what happens with the lymphedema. So you would be on a retrospective study, basically put in a registry. We would take measurements, and then we would follow up with you going forward. So it is possible to still track your data. Yeah, can GLP-1s reduce the risk for lymphedema? think our study, at least for axillary dissection, was the only study I saw published looking at risk reduction for lymphedema. Again, it's a retrospective study, not a prospective high-level study, but there was such a big difference, and we know the mechanisms of GLP-1s that I think there's probably something to this and deserves prospective study and may be beneficial. More questions on lipedema of the same type. I think obviously this is of big interest. How long after starting GLP-1s does the benefit of lymphedema manifest? This is also an unknown. We're using this drug, patients who are interested in using it oftentimes for a few months to get them optimized for surgery. So we want them to be as good as possible, their lymphatic system as good as condition as possible. So not all of them are using this long term, and we just have to see. So this is a patient that was actually seen by Dr. Elkwood in Fort Lauderdale who has severe primary lymphedema. We mentioned early findings with a GLP-1 receptor agonist, and this person started taking Manjaro, and it has been helping with swelling and mobility. I just want to say thank you, Karina, for sharing your story. I think this is really important for us to hear, and I think just all the more reason there's something to this. Are some GLP-1 injections better than others? I'm not an endocrinologist, so I don't want to speak definitively, but based on studies, the newer versions like tirzepatide shows a higher amount of weight loss. I don't know that correlates with a better effect on lymphedema or not. Okay, this is another Peggy. Thank you so much for sharing your experience. She's had lower extremity lymphedema for over 26 years. She's on week 10 of using this and seeing great results. That's amazing. I think this is all the reason why we're doing this study, and we can actually quantify how much of a benefit to patients. If you have primary lymphedema that's long-standing for a couple decades or more, what is the benefit? If you have early stage lymphedema, what is the benefit? What are the downsides? What are some of the risks? So this is a question from Joanne. So the drug helps people lose weight, and then that weight loss prevents the potential lymphedema. We are presuming, possibly, we don't know, to really show the cause, we'd need to do a randomized study, or at least a high-level prospective study to kind of get a sense. The mechanism of action, definitely we know that weight gain worsens lymphedema. We know obesity puts you at high risk of lymphedema. We know that reducing that, putting you in a lower bracket, in our study of BMI less than 25, had significantly lower risk of lymphedema than a BMI greater than that. So I do believe that's one mechanism of action, but there may be other mechanisms because the GLP-1s affect, they reduce inflammation, they affect the immune system, which is part of the problem in lymphedema. Will leg lymphedema be included in your study? Any restrictions for participants? We are ironing out. We're in the last. I don't want to blanket statement everything because this would have to. This is going to go through the IRB process shortly. So I will give all of the. We can perhaps give through LE&RN all of the information for inclusion criteria. Who would qualify? Who wouldn't qualify? Even those who don't qualify for prospective study, we would still, if you're interested, want to track your results. So your measurements would be tracked, and you could know how your limb is doing over time in our registry. I couldn't really make a recommendation for brand or product for GLP-1s. I think it's different for everybody, and you should speak to your doctor. In Europe, tirzepatide specifically is indicated for lipedema, and it seems that it helps to diminish on their trapped fat. From Mary, thank you for letting me know. I was not aware of that. I think That's very, very important information to know. What is your understanding of GLP-1 and loss in muscle mass? I think that's an important question. It's definitely a topic of interest. Again, I'm not an endocrinologist, so I'm not a high-level GLP-1 expert, but I'm trying to learn as much as possible. I read as much as possible. I speak to other experts. It is a concern, but there have been conflicting studies on this. So I don't know. I don't really know. I don't know that there's a definitive answer. That I think the jury is still out, and I think it's a topic of a lot of interest. Part of our prospective study is using the bioimpedance SOZO, which gives us segmental body composition. So this is something we are actually going to be looking at. I've been on GLP-1s for my PCOS and primary lymphedema for 3 years, and I have CLT notes and proof that this works. How can we get this approved for lymphedema and Medicare? I'm currently having to pay out of pocket. I'm 100% with you. I think that getting anything approved by Medicare or an insurer requires high-level data, more than just you can have 1 million patients that say it works, but you need high-level studies. And that's part of the reason we're doing this study, to see what the data shows. And if the data shows overwhelmingly that under prospective study, GLP-1s are treating a highly morbid and disabling condition, a lifelong chronic disease, then we have a leg to stand on in terms of saying, listen, lymphedema is a chronic, progressive, relentless disease. This affects millions of people in the U.S. and many, many millions worldwide. And this drug has been shown by these studies to successfully treat it. And in fact, I think it's an amazing thing. Never before is there a widely used drug that's FDA approved, that's actually been, people are using it on their own and seeing results from lymphedema. And it would be my hope that whether it's this drug or any drug, I'm not married to any particular treatment modality, but if this drug on prospective study on high-level data is reproducing all of these great results that you're seeing, then you can go to an insurer and have an argument where you could potentially get coverage. Yeah, this is another good question from Trish. Similar along the same vein, since the drugs have no indication for lymphedema, how would patients get the drug? I have secondary lymphedema, both legs, after a gynecologic cancer. And this is gynecologic cancers we see, that's the second most common type of secondary lymphedema. We see a lot of it. The risk of lymphedema after a pelvic node dissection or groin node dissection is even higher than axillary dissection. And lower extremity lymphedema is extremely challenging, particularly in both legs. So I'm with you. I feel for you. I don't really have a good answer. At this point, we're doing the best with what we have. I know there are patients that are going to compounding pharmacies and paying out of pocket, where the out of pocket costs are much lower than the manufacturers, traditional manufacturers. But I don't know much about compounding pharmacies, and I wouldn't make necessarily a recommendation. But I know that that's kind of the state of where patients are seeking the drug. Okay, this is Dana. She's wonderful. Good to hear from you. She's a CLT in Manhattan. Would there be a minimum BMI for the study and for the use of semaglutide to improve lymph? There will be a minimum BMI because we don't want to, in the first iteration of any study, we want to be very safe, but it's not going to be greater than 30. It's probably, we're still in discussion and fine tuning this, but it's probably going to be greater than 25. But I don't want to necessarily exclude patients from a prospective study that may benefit. At the same time, I don't want to put anybody at risk. These questions are going to be answered with endocrinologists and oncologists. Oh, and this is Karina. She's about to start her therapy. Would be very interested to see how you respond. Karen, I'm a patient with a normal BMI and fat dominant secondary lymphedema in one leg. If that patient lost weight with GLP-1 receptor agonists, would the weight loss be evenly distributed throughout the body, or is it possible the impacted leg would lose weight at a faster rate? I don't know. That's why we're going to be doing this. We're going to be doing this study, but it's a very, very important question to answer, and that's why we're getting segmental body composition. I have Annalise. I have a primary lymphedema and been on Manjaro for a few years. I've consulted with Dr. Single, great doctor, of Beth Israel Deaconess Medical Center, and am not a candidate for limb reduction. I have an existing lymph node transfer, which helps somewhat. I can say I do better with my leg swelling when I weigh less. However, I've been diagnosed with lymphedema, and that is not affected by my weight loss. What is your opinion on such a case? Unfortunately, Annalise, I couldn't give you an opinion specifically on your case. I would have to see all the details. We'd have to see you in greater detail. Thank you for your input on CGMs, the continuous glucose monitor, and its relevance and importance. Physiology based on input of non-carbohydrates is very beneficial. I agree. It's changed, honestly, it's changed my life, and it's kind of, I'm hungry for more data, and I think there's a future where, you know, your watch will tell you the whole status of your physiology as you're putting all kinds of foods in. I wish I could know the cholesterol content, the, you know, saturated, unsaturated fats. I think the future is very, very interesting. Do you take new lymphedema patients? We do. Our nurse practitioners are on the front line of evaluating all patients. I'm a surgeon, so I would see patients that are ultimately interested in surgical consultation, but we're interested in all patients with lymphedema, and I would just please reach out to us by email or phone. How about treating primary lymphedema in both legs? Again, great question. We will be enrolling patients for primary as well. This is Mary. She was completely unable to walk from both lipedema and lymphedema after 3 doses of tirzepatide. I was completely unable to walk from both lipedema and lymphedema. And after 3 doses of 0.25 mils of tirzepatide, I was able to walk again after not walking without a walker for over 3 years. Wow. It is not covered. It is not covered for me, and I pay $700 a month, which is clearly you have a medically necessary condition, and in a perfect world should be covered. That's an amazing story. Eugene, how can AI ML analysis of electronic healthcare records be helpful in this area? I think it's a phenomenal question. This is an area we're actively looking at and researching. So, you know, I think there's a lot of data on GLP-1. A lot of people are using this, and so we can kind of find out multiple answers to multiple questions. But if you're actively researching and have an idea, I'd be happy to collaborate with you. Julie, I'm a colon cancer survivor of 15 years. Amazing. I'm a lipedema patient and currently use tirzepatide for weight loss and have been amazed by the difference in my mobility, inflammation, and swelling with its use. This is great. This is really important to have this discussion. I think there's a ton of interest. Would you accept volunteers for trial from Ontario? I think that the only issue is that we need to measure you. So if you're willing to come down to northern New Jersey, we would be more than happy to do that. But it's not something we could do remotely. We would have to measure you, take your bioimpedance. We have a Lymphatech, which measures your limb volume in a very consistent way, as well as validated questionnaires and so forth. Kathleen, I'm a lymphedema therapist and interested in whether using compression while on GLP-1 agonists may mitigate some side effects of nausea, etc. There is a study, Mendoza et al., 2017, showing reduction in nausea due to early pregnancy with leg compression. Maybe another reason to have lymphedema clients wear compression during GLP-1 treatment. I mean, I'd have to look at the study. I'm not familiar with the study. I'm not sure I would necessarily I don't think it's necessarily a good analogy from pregnancy-induced nausea and compression to a GLP-1 induced nausea from a drug. But regardless of that, we recommend all of our patients to work with a lymphedema therapist. So I'm fully with you with compression. And compression is a whole other topic, but tangentially, compression is also an art. And there are a lot of patients out there we see every single week that said, I tried compression and it didn't work, when in fact the compression wasn't just wasn't fitting right. And so the actual fitting of the garment for compression to work, some of the patients aren't even aware that if like they'll say their hand or their wrist swelled, and maybe where the glove and the sleeve met was too tight, causing a tourniquet and a pinch point effect that's going to cause more swelling simply because it was too tight at one point. So the garment fitting is a whole other topic. And I think a lot of patients miss out on the benefits of compression simply because they got the garment, it didn't fit. They thought the garment made them worse, but when in fact they should go back to the lymphedema therapist and maybe make adjustments as necessary. So I would encourage all patients who maybe don't think they've benefited from compression to circle back with your lymphedema therapist and really dial in that garment. Can I take a GLP-1 medication for lymphedema prior to surgery to take out some of the volume? It is taking a toll on my mental health. I have lipedema in my upper legs and buttock. I'm from Los Angeles. I would like to take a GLP-1 medication in pill form and was a triple negative breast cancer survivor, twice in remission. Can you talk about how you do breast revision surgery without the D-flap? That's a lot there. So a couple, like there are a lot of questions in there. And you're dealing with a lot. So both lipedema and triple negative breast cancer survivor, twice in remission. So upfront, regarding the triple negative breast cancer, there's really not any real world human data that I've seen specifically for triple negative breast cancer and GLP-1 in terms of safety. The only data I've seen were those two publications, both in a lab, one in a dish and one in a mouse model, where it seemed to promote triple negative breast cancer cell growth. So you're putting breast cancer cells in a dish, triple negative breast cancer cells in a dish, metaphorically sprinkling GLP-1 on, and they'll see some tumor progression. Now, does that actually happen in a human with human doses in a human body? I don't know. So anything that I would do, particularly in your case, I would speak to your oncologist and clear first with your oncologist before taking GLP-1. In terms of revision surgery without doing the deep flap, we'd actually have to see you. I couldn't give you a specific recommendation. I do not have obesity or diabetes, but do you think if I used over-the-counter wearable glucose monitor to check insulin level, could that somehow help my lymphedema? I think yes, it possibly could. No such study has done that. But honestly, I think pretty much everybody should, at one point in their life, use a continuous glucose monitor for like a month just to see what they're eating, because a bunch of us are on a trajectory to get diabetes. And a lot, particularly in the US, our diet these days, and I'm not obese. I'm not somebody that my doctor was like, you look healthy and everything. I was checked into the ER with a blood sugar of 465. So I had way out of control diabetes. And part of that was my diet. I would eat fish and stuff, but I also eat a lot of prepackaged nutrient grain bars and whatnot, processed foods, oatmeal that I thought was good for me, but threw my blood sugar way high, rice threw my blood sugar through the roof. So that's not going to do the same for you or for somebody else. And you need to know in you, what the food does in you, not a generalized diet that may work for somebody else. But I think you should do it. I think like everybody should try it. Are you planning to study people with lymphedema that have low to normal BMI? I think to see if the effect is because of anti-inflammatory action rather than weight reduction. I think it's an important study, but I'm not going to do that study right now. Right now, I think there are patients with lymphedema who already have obesity and or diabetes who immediately would benefit from the GLP-1. And there are going to be people who don't have obesity and diabetes, but still have some weight they'd like to lose. I'm a little gun shy of treating somebody who is at ideal body weight yet, but I do think it's an important study to do. Certainly, they may not be on the prospective study, but if you are using GLP-1s, we would want to hear from you. Another question about muscle loss. Does it have a role in muscle loss? If so, doesn't the contraction of muscle help the lymphatic flow? And, could this not affect the lymph? I think it's a great question. Definitely muscle pumping affects lymph flow. I don't know. I've seen articles published that don't show muscle loss and articles published that show there may be muscle loss. In my own, just anecdotally, I've definitely lost weight, but I don't feel my lean muscle mass has significantly dropped to any point where I'm noticing it. But at the same time, I'm doing strength training for the first time, so I'm building muscle that I hadn't worked out in many years. On the flip side, patients who have obesity that have lymphedema are in a really bad spot because the lack of mobility also limits their lymphatic flow. And so if the obesity can be treated, if they're getting into an exercise program, their lymphedema could benefit. Oh, this is from Yvette. Thank you. We got this question from the ILSE email. Hi, I have primary lymphedema. I wonder if I may be a candidate for GLP-1 study. I have a normal BMI, I'm 46 and live in Iowa. I have had a few ICG lymphography scans and my lymphedema is at an advanced Stardust stage. Please let me know if I can send any information. I think we can reach out to you. Our team can reach out to you and get more of the details. I see there's a lot of interest in patients who are not necessarily overweight or diabetic, but are struggling with lymphedema. And I hear you. Maybe we should dig a little deeper. But again, I'm going to dial in this study with endocrinology as well as oncology to make sure the first version of this study is safe and beneficial. And I think once we have a foothold, then we can go into we can branch out from there. Hello, I was diagnosed with May-Turner's syndrome, secondary lymphedema in my left foot and leg. Participated in the study at Stanford with Dr. Roxon. That's great. However, I now live in a small town in Alaska. What would the study entail, and do you foresee a larger study to be available for those of us in remote areas? So this is really a first pilot study. I've not seen any prospective study done. So we first want to gather some prospective information, and then after that, as you're doing these first level studies, it generates more questions, and it actually makes the next study a lot better because you now understand better questions to ask or more specific questions to ask. And you also learn how to ask them. So I don't know of a large population study. I think with any study, you're going to want to get measurements, objective measurements, so you can quantify a change. I do think you could remotely do a study where you have validated quality of life questionnaires done before and after treatment. But ideally, you also have some limb volume measurements, bioimpedance, segmental body composition. So I want to do a high resolution study so I can give you more information to tell you and give you better information so you can make a decision. So for that, we need the patients actually to come here to New Jersey, get measured, both segmental body composition, bioimpedance, limb volumes, validated quality of life. So we have a lot of high-level information. There are a lot of questions. I'm going to have to wrap up soon. Adrian, what questions should a patient with primary congenital lymphedema and a history of axillary dissection and cancer, but not breast cancer, ask a doctor about using GLP-1 RAs? I think that's a lot. That's a lot you've been through. I think really the question is there anything specific to your cancer history or cancer treatment that a GLP-1 receptor agonist may interfere with? I would leave that to your oncologist. Regarding your overall, the general treatment of GLP-1s, I would ask your doctor. All of these have potential side effects and adverse effects. And as a person who's not an endocrinologist and primary care doctor, I would leave it to them. What brand of continuous glucose monitoring have you used successfully? I mean, this is not an endorsement. I have no disclosure for any company. There is the only over-the-counter continuous glucose monitor that I'm aware of is called Stelo, S-T-E-L-O. So when I last checked, it was $99 for a month. It doesn't require prescription. I use the Dexcom G7, which I like. I was on the Dexcom G6, the G7. It warms up a lot faster. It's smaller, so it doesn't snag on things, especially if you're exercising. But I know there's also the Libre out there. I think any form of continuous glucose monitoring that's giving you feedback, immediate feedback, is great. Okay, what info is available to people treating lymphedema about weight loss? They can be very uninformed about modern concepts in weight loss. My lymphedema doctor gave the unhelpful advice to just eat fewer calories and exercise more. The lymphedema leg makes it difficult to exercise, and even at very low calorie intake, I struggle to lose weight. Additionally, I keep losing height, making my BMI increase at less weight than I was a few years ago. So I think this is the exact reason why we've seen benefit with GLP-1 receptor agonists. I think medicine in general doesn't do a very good job, as you've experienced, as I personally experienced, with specific things you can do to improve your body composition and overall metabolism, not just pure weight loss. Weight loss may be part of it, but overall nutrition. How much protein intake should you take? How much exercise and what type of exercise and how frequently should you do it? Sleep is also part of this. So as a surgeon, I mean, historically, surgical residents and many people in medical residency are not sleeping. A lack of sleep causes high levels of cortisol, and high levels of cortisol, the stress hormone, increases your fasting blood glucose and can wreak havoc with other parts of your body, your general metabolism. And many in the US are working very hard, especially with families. There is no sleep. And so sleep becomes an important part of this cocktail. And I think GLP-1s are kind of almost a gateway drug into the health environment, because many people will then get a continuous glucose monitor. Many people will then, through this online algorithm, get fed information about sleep. I think Peter Attia does a great job. His book, Outlive, was really phenomenal. I think it's had a huge impact on many people. And I think that's a good place to start. He actually makes specific recommendations with exercise and diet. And there are a lot of other very savvy, very high impact people out there that have done a lot of good. Okay, so this is a person that, not all the data is going to point in the positive direction. So this is a person, thank you for sharing your experience. I had a great PT for my lymphedema and lipedema and lost 60 pounds so far in Ozempic, but see little change in the lymphedema, but good labs for my diabetes type 2. So I think this is important information. I think it would be a fantasy to say that any drug 100% is going to be 100% effective. Similarly with surgery, we cannot guarantee any result with surgery. Unfortunately, there are disappointing results. there are drugs that don't work. Many people switch drugs. The type of GLP-1 may have an effect. Same thing for diabetes. There's not one diabetes drug that always works, but it sounds like Ozempic did an amazing job for your type 2 diabetes, which is great. So I think it's important to just look at the data as it is, warts and all. Does gluten-free or lactose-free diet help with lymphedema? I really don't know. A diet is difficult to study because there are a lot of other variables, but I honestly don't know. Have you heard about gastroparesis as a side effect of GLP-1? Is this worrisome? It does delay gastric emptying, and so that's a known mechanism. And I'm sure that in some, that can be severe to the point of there have been patients that have had vomiting and nausea from this drug. And in fact, as a surgeon, we want the drug held usually for, I believe, about 2 weeks before surgery because of delayed gastric emptying. You don't want to put a patient to sleep and put a tube down their airway where they can vomit and aspirate. So I think that in the setting of surgery, it is a concern, and that's why we would hold it before surgery. But just in general use, I think I would ask your doctor specifically for your medical situation. And this can not all patients on GLP-1 lose weight? 100% true. I do not think a GLP-1 or any drug or any surgery is going to be 100% effective. That doesn't mean that it can't benefit a lot of people. We still do surgery on patients, not because every single patient benefits, but because more patients than not do benefit. And this would be the first drug I've seen that's FDA approved, already widely used, where there's a lot of data on safety, use, and even longer term outcomes, that it's worthwhile having this discussion and worthwhile doing a study to see what the data is. You know, of all the people we put on GLP-1s, how many actually lose weight? We're definitely going to track that. There's been plenty of prospective study, though, on weight loss and GLP-1s, including randomized controlled trials that I cited, showing an overwhelming benefit over placebo. Umberto, what is the second medication you mentioned after semaglutide? Tirzepatide, there's liraglutide. There are a number of different ones out there, but I would speak to your doctor. So Meredith, I'm petite, do not have diabetes, have had lymphedema over the past 15 years. This is the first introduction regarding GLP-1 being linked to helping lymphedema. Would love information. I hope this is as much information as I have right now. I think that we'll get more information when we have the results of prospective study, and we just share the data openly. Have I seen total reversal of type 2 diabetes? I do not treat type 2 diabetes. I'm not an endocrinologist, so I couldn't say. Our study is not blind. Like I said, I would have liked to do this as a placebo randomized controlled trial, but we would need high level funding for that. So this would be patients that are voluntarily taking the drug and know they're taking the drug, obviously. Who are the endocrinologists you recommend? The endocrinologist that I worked with, who is outstanding and an academic powerhouse, is Dr. Emily Gallagher. I think I have to wrap this up, and this has been tremendous. Oh, Andrea and Bruce just saying hello. Hi, Andrea and Bruce. I think I have to wrap up now. And it's been tremendous interacting with you. This has been very informative for me. And I think it's also going to help. Oh, Catherine. Wow, Catherine Seo. I want to say hello and thank you. It's so great to see your name up there. And of course, let's definitely connect. I want to thank everybody here at the LE&RN team. Thank you so much. And I appreciate your attention.